I'm Dr. Ajna. Today we'll be dealing with a topic called behavior science in pedodontics, and today we'll be looking mainly into behavior science and the non-pharmacological methods of behavior management. To begin with, some definitions that we should know. So what is behavior? Behavior is defined as any change observed in the functioning of an organism. Now, what is behavior science? So, behavior science is the science which deals with the observation of the behavioral habits of man and lower animals in various physical and environment, including behavior, pedodontics, psychology, and social anthropology. Now, what is behavior pedodontics? So, this is something. It is a study of science which helps to understand the development of fear, anxiety, and anger as it applies to the child in the dental situation. Now into the different classifications of child's behavior in the dental clinic. There are different doctors or different scientists who have suggested this. First is Wilson's classification, next Frankel's behavior rating scale, then Lampshire classification, Wright classification, and Gracier-Godey's classification. To begin with, Wilson's classification. He proposed this in 1933. There are four types of behaviors that he has observed. First one is the normal or bold. So here the child is brave enough to face the situation. He or she cooperates and is friendly with the dentist. Next is tasteful or timid type of behavior. Here the child is shy and does not interfere with any dental procedure. Next is hysterical or rebellious type of behavior. This is mainly influenced by the home environment. He or she throws tantrums and is rebellious. And next is nervous or fearful type. So here the child is tense and anxious and it has fear of dentistry. So those were the four classification of under Wilson's classification. Next we move into Frankel's behavior rating scale. This is also seen as he has observed four types of behavior and he suggested this in 1962. So first is the definitely negative. This child refuses treatment, cries forcefully, extremely negative behavior and associated with fear. So this is represented as negative. And then next type of behavior is the negative behavior. Frankel's behavior rating scale shows a negative behavior when a child is reluctant to accept treatment and displays evidence of slight negativism. So this is represented by a negative symbol. Next is Frankel's positive type of behavior, that is the child accepts treatment and may become uncooperative if the child has a bad experience. And this is represented as plus sign. Next is definitively positive type of behavior, where this is a unique type of behavior where the child looks forward or understands the importance of good preventive care. This is represented as plus. Next into Lampshire's classification, which was proposed in 1970. This has the first type of child's behavior is cooperative, where the physically, mentally relaxed child is physically and mentally relaxed and cooperates during the treatment. Next is tense cooperative, where the child is tensed and cooperative at the same time. Next is outwardly apprehensive. So this type of behavior is seen, and when this type of behavior is seen in a child initially avoids treatment, then avoids talking or eye contact with the dentist, but eventually the child accepts the treatment. Next is a fearful child. So this requires considerable support. This behavior in children requires considerable support to overcome the fear of dental treatment. Next is stubborn or defiant. So they passively resist treatment by using previously successful techniques. So children who show this type of behavior would have had experiences where they have been able to avoid the dental treatment by doing different behaviors. So they know which behavior will help them escape the dental treatment and they will keep doing that type of behavior. Next is hypermotive. So here the child is acutely agitated and resorts to screaming, kicking, etc. Next is handicap, where the child is physically, mentally or emotionally handicapped. And the last is emotionally immature type of behavior. Now into rights classification, which was proposed in 1975. So there are only two main classifications, that is cooperative or uncooperative. So cooperative is obviously the positive behavior and uncooperative is the negative type of behavior. Now cooperative has three subclasses under it and uncooperative has six subclasses under it. So, moving to the cooperative type of behavior. There are three types. There is the cooperative behavior, lacking cooperative ability. Third is the potentially cooperative. So the first is cooperative behavior, where the child is cooperative, relaxed with minimal apprehension. Next is lacking cooperative ability. This is usually seen in children between 0 to 3 years, or they are too young to cooperate, or the disabled child, physically, or handicapped, physically or mentally handicapped children. Now, the potentially cooperative has a potential to cooperate, but doesn't do so due to the inherent fears. Moving on to the uncooperative, the children under the uncooperative category of rights classification. Under this comes uncontrolled, hysterical, incorrigible. First one is so usually seen in preschool children at first dental visit. They show temper tantrums, tears, loud crying, physical lashing out of hands, kicking, screaming, etc. They refuse to cooperate with the dentist. Next is the defiant behavior or the obstinate behavior. They may be seen in any age group and they are usually seen in spoiled or stubborn children. But however, they can be made to cooperate. Next is tense cooperative. They are somewhere between, in the borderline between positive and negative behavior. They do not resist treatment and the child is tensed at mind. Uh, Next is the timid behavior or shy, usually seen in overprotective children at the first visit. Um, they are shy but they cooperate to treatment. Next is winning type, or that is they keep complaining during the treatment. They allow the treatment to happen, but throughout the treatment they keep complaining. Next is the stoic behavior. Stoic behavior is usually seen in physically abused children, where they cooperate and passively accept a treatment without any change in their facial expression. Now into Gracia Godai's classification, which was proposed in 1986. There are mainly 7 classes. So first one is the fearful child. So here the child resists to enter the dental treatment or the treatment room itself and cries and screams, etc. They could be passive. Some children may be passive, and accepting treatment, but they state their fears. Next is timid type of behavior. They enter the treatment room very cautiously. They hesitate to look at the dentist or other staff. They most of the time they are very thoughtful and they uh, keep staring at the floor. Next is spoiled type of behavior. So in this type of children, they enter clinic with arrogant and proud behavior, and they neglect treatment and they state their preferences and give orders to what should be done. The fourth type is aggressive type of children. They scream, they kick, and they show all sorts of aggressive behavior. They don't open their mouth for treatment. Next is adopted. So this is somewhere between it's a combination of a spoiled and fearful type of behavior, and they could even present symptoms of or characteristics of a timid child. Next is a handicapped child. So the child has a mental or physical handicap and they need special care. Last is the cooperative child who cooperates most probably cooperates well with the treatment. Now into the factors affecting the behavior of children in the dental office. So under this mainly there are situations like which are under the control of the dentist or under the control of parents, and there are other variables too. To begin with, under the control of the dentist comes the effect of dental office environment. So we should make sure that the dental office is doesn't instill fear in the child, or they don't become more and more apprehensive towards the treatment. Instead, we can try to make it more warm and homely. Then we have to have colorful posters, TV, etc., like which attracts the children, toys or places that they can enjoy. Then colorful magazines can be, or children magazines can be put up there. Also, the dental auxiliary should be, especially the receptionist, should be very kind to the children, and we should make sure that the child doesn't have to wait for a long time in the reception area. And preparation, we can do a little bit of preparation for this before the child comes to the dental clinic. That is through phone calls, to emails, we can tell the parents how to prepare the child. So next is the effect of the dentist activity and attitude. So Jenks in 1964 described 6 categories of activities. The first is data gathering and observation. So under this comes, we should ask the parents to fill in a questionnaire about the child, so we can gain more information about the child. Also, we can observe the child, how the child is walking, where is the child looking when he or she enters the dental clinic. So this is the first activity. Next is comes the structuring. So in this comes the how we, it is where we establish the guidelines of behavior that we expect from the child. Next comes the externalization. Here we are trying to take away the attention of the child from any fearful stimuli. Under this comes distraction. So we try to distract the child from the fearful stimuli and get them involved into something that they find it more interesting. Next is empathy and sympathy. So we should know that as dentists, even though we are dentists and we are expected to finish a treatment, we should keep in mind that the child might be fearful, and we should understand and get understand their feelings well, without losing the our objective of completing the treatment. Next comes the flexible authority. So this is when the dentist makes different compromises to meet the different needs of children. So because in some mentally handicapped children, or if they're physically handicapped, we need to adjust our attitudes and expectations of the children, from the children. So this will make them more comfortable. Last is educating and training. So in this, under this comes we have our ability to teach the children and the parents the importance of good oral health and why we are doing these treatments. Next is the effect of dentist attire. So if the child has undergone any fearful medical treatment or a prolonged hospitalization, etc., they will be obviously scared of the white coat. So what we can do is we can use other colors of our attire, can be other colors, or we can use something with a coat with more child friendly prints on them. Next is the effect of another person's presence in the operatory. First is the presence of mother. As we know, in children who are in their preschool age or before that, the presence of the mother, they have a separation anxiety. So the presence of the mother is very important when the dental treatment is going on. But older children don't necessarily need this. For if also the presence of older siblings. So if both the patients are both the children of the family are our patients, it is very good if the older sibling is is of good behavior, because the younger children will look up to the older children as a role model and try to model whatever they do. If the older child shows good behavior, it is good if we can show them to the younger child. Next is effect of the length or the time of the day of appointment. So here we should make sure that children don't sit beyond about 30 minutes. So we should try to keep the appointments less than 30 minutes, and also early morning appointments. That is in our appointment schedule. It is better if we can keep it with the child in the initial hours of opening the dental clinic, because then we will also be in a nice attitude and the child also will be fresh in the morning. Now into the other factors which affect the behavior of children. So this is the other variables which are out of the control of the dentist. First is growth and development. So growth and development is something that is specific to each child. So what we should know is that children with growth deficiencies or congenital deformities like cleft lip and palate or any other such deformities already have psychological trauma from the society. So also mentally retarded cerebral children like who have cerebral palsy, they cannot meet the expectation of the parents or society or the dentist. And also in very young children, uh, we cannot expect them to behave the way we want. So this is one factor which is out of the reach of the dentist. Next is nutritional factor. So nutrition has indirectly has an effect on the growth and development of the child. Also, some if the child is has a nutrition deficiency, it affects the milestones of the child. Also, if the child is used to very high sugar foods, or they consume foods with high sugar, then the child will have a very irritable type of behavior. And if the child is a hypoglycemic, they start showing criminal type of behavior. Next is past dental experience. If the child has had unpleasant or past dental experience or hospitalization or surgical intervention, sickness, etc., the child will obviously be uncooperative. Next is genetics. Genetics play an important role. Also, the environment around, or the people, the society around, influences or modifies this genetics. Next is school environment. So it is said that the child's development happens 50% at home and 50% at school. So here there are teachers and peers who they have an important role in the child's life, and usually seniors are looked up as role models. Next is socio-economic status. So children who are from the high socio-economic status usually have everything for a normal development, for their normal development. However, if they get everything that they want or above what they want, the child may be has showing a spoiled type of behavior. However, children in the low socio-economic status develop a resentment, and they're tense and show less. They're tense, and they seem to have got less attention, and they look more neglected. Now into the factors under the control of parents that indirectly affect the behavior of children. First is the home environment. So it is said that for a child, their first school is the home itself. So they learn many things from home. So they learn from the behaviors, also the actions of individuals present at home, especially the mother. So in broken families, what happens is the child grows up to be very insecure and inferior individuals. Next, we should know that also the behavior of the child postnatally is influenced by the mother's emotional status when child was in the womb. Next is family development and peer influence. So this is basically the position of the child, or the status of the child in the family, or the parental attitudes towards the child. So if there are internal family conflicts, what happens is the child becomes very frustrated emotionally. And also we should know that younger children always try to imitate their older siblings. Next is maternal behavior. So we should know that the maternal influence start on a child starts long before the child is even born. This somatic development happens based on the nutritional status of the mother. and neurohormonal system transfers emotion to the baby. Now, agents, if the mother uses agents like alcohols, totipotent drugs, or if the mother smokes, etc., this affects the development of the baby or the child. Now looking into the maternal influence on the personality of the child. So we should know that the mother-child relationship mainly falls into two categories. That is autonomy versus control. The other one is hostility versus love. So autonomy is when we leave the child, or the mother leaves the child to grow and develop properly, or the uh, mother places a very hard control over the, or places boundaries for the child, and the child is not able to develop properly. Hostility is where the mother doesn't show any sort of love towards the child and more or less neglects the child. Or the other extreme is where the mother shows lots of love to the baby child. So the mother-child behavior interactions are mainly seen as overprotection, overindulgent, under-affectionate, rejecting, or authoritarian. Also, we can look into the effect of maternal anxiety. Now, looking into the effect of mother's behavior, which indirectly affects the child's behavior or directly affects the child's behavior. First, we should know that the bond between a mother and child is very close, or they are in a close relationship. But when this love is over exaggerated, there can be overprotective or over indulgent mothers. So, the first type is the overprotective or dominant mother. So here, mainly it may be because the child was born to them late, or the child is sick or handicapped, or it's their only child. So the child is not here. The child is not permitted to use their own initiative or ability to make their own decisions. The mother takes active part in all the child's social activities, and thus what happens, the child doesn't learn to cope up with any of the problems. Now the child in such children will be very submissive, shy, and anxious, and also they fear new situations, and they lack self confidence, and however they might be very polite and obedient and disciplined. So how we manage such children in the dental clinic is by creating self confidence in them. Now introducing them to the equipments or auxiliaries in the dental office, and also applying the tell show do technique. Next is the overindulgent mother. So this is also a type of exaggeration of love, where the mother is getting too much involved into the child's things. And here the child is seen as aggressive, demanding, and displays temper tantrums. So here the child expects constant attention, and it's more like a stubborn or spoiled child. So the child tries to dominate the dentist. However, the child may be well behaved and well adjusted, but a good rapport can never, most probably not be established between the child and the dentist. That's a very tough task. Next is the under affectionate. So in this case, the child is devoid of love and care. This can vary, under affection can vary between mild detachment from the child to complete neglect of the child. So there are many reasons why this can happen. This may be because the child is was not anticipated to be born, or is an unwanted child, or the mother is unhappy due to family problems, or hamper or the child is blocking the mother from, or is causing a difficulty for the mother to achieve her ambitions in life. So then what happens, the child lacks a lot of attention and has emotional problems. So the child here is usually well behaved but unable to cooperate, shy, and may cry easily. So what we can do is we can show, as dentists, we can show affection and love, and thus the child will start responding to us in a expected, or in the way we want. Next is rejecting type of mother. So this rejection is can be vary from physical abuse to verbal ridicule, and the mother may be giving severe punishments, violence, and doesn't spend time with the child or money over the child, etc. Or also there is emotional, physical, and also neglect of the child's health. So the child always tries to gain attention of others and wants most this type of children are most difficult to deal with in the clinic, because outwardly they appear to be well behaved, but emotionally they're very insecure. Next, so how to manage such children is we can develop confidence in the child by showing some love and care, and also we should try to meet their demands. Last is the authoritarian mother. So here the mother is, sets certain norms for the child, and uh, he or she is expected to follow it. So such children do things very slowly. They follow instructions very slowly, and they may do everything, but not with the full they do it with resentment. So they want to just escape the treatment or run away from the dental setup. So such children are evasive and dawdling. And also now into the pediatric triangle. So this is we should know that the apex of the pediatric triangle is always the child. The child is the point of concentration. The parents and the dentist, both our attentions or our relationship is with the child patient. And then we should also keep or dentist should also keep a relationship with the parents and vice versa. So apex of the dental or pediatric triangle is the child itself. Also society plays a role in the development and the behavior of the child. Now moving into behavior management. So now we are going to look into some definitions related to behavior management. So this was given by a Wright in 1975. Behavior management means by which it is a means by which dental health team effectively and efficiently perform dental treatment and thereby instill a positive dental attitude. So basically, this is methods by which the dentist is not only able to complete the dental treatment required by a child, but also instill some sort of positivity within the child so that the child does not fear dental treatment in future. Next is behavior shaping. It is a procedure which slowly develops behavior by reinforcing a successive approximation of the desired behavior until the desired behavior comes into being. So this is like we are showing the child or molding the child, and we are reinforcing what is expected of the child until we get what we desire. Next is behavior modification, the attempt to alter human behavior and emotion in a beneficial way and in accordance with the laws of learning. Now, behavior management can be classified into non-pharmacological and pharmacological approaches. So, non-pharmacological approach is basically the psychological approach, and the other one is the pharmacological approach. So, in the non-pharmacological approach, first comes the communication, next is the behavior shaping. So, under behavior shaping or modification comes the desensitization, modeling, and contingency management. And next is behavior management itself. So here there are about 9 methods by which this is done. First is audio analgesia, biofeedback, voice control, hypnosis, humor, coping, relaxation, implosion theory, and aversive conditioning. Next is the pharmacological methods. First is pre-medication. So in this comes sedatives, hypnotics, anti-anxiety drugs, antihistamines, etc. Then there is something called conscious sedation, and the last, general anesthesia. We will now look into the non-pharmacological methods of behavior management. To begin with, the first one is communicative management. So this is universally used for both cooperative and uncooperative child, as stated by Chambers in 1976. So this is the fundamental form of behavior management, and it helps to build a child-dentist relationship. Communication is a means by which the dentist himself makes himself known or understood by the child, what he or she as a dentist expects from the child. This helps relax the young child, and the way of communication differs with age of the child. The vocabulary of the with different age, the vocabulary of the child differs. So we should understand that, and the communication is usually based upon the age and the vocabulary of the child. And this helps to make the child more comfortable and relaxed. So verbal effects are delineated through selection of words or sounds, tone of voice, and voice inflection. So according to Koch. So we should use the correct type of words in the correct tone. That's what it states. And verbal communication is best for children less than 3 years, and patient should be addressed by their name. And we should make sure that we compliment his or her appearance or the way dress they have worn, etc. Then we should ask about the child's likes and dislikes. And if we sit with the child at eye level, it helps them feel a more comfortable and friendlier atmosphere. So communication is like a multi-sensory process, which includes a transmitter, who's the dentist, or the word that is spoken, that is the medium, and the patient is the receiver. We can use euphemisms, that is substitute words for or we can substitute scary words, which for the child it's scary. So we can substitute those words with less scary words. So here are some examples. First is rubber dam. We can substitute it with the word raincoat. Then radiograph, we can call it tooth picture. Sealant is we can describe it to the child as tooth paint. Anesthetic solution, or the process of giving LA, we can describe it as the water that puts the tooth to sleep, or putting the tooth to sleep. Next is air syringe. We can call it wind gun. Suction, we can call it as vacuum cleaner. And alginate as pudding. So now what is reframing? So reframing, as described by Benjamin Peterson in 1999. So basically reframing is bringing a situation and changing the way it appears to the child. So I'll read this. So taking a situation outside the frame that up to that moment contained the individual in different conditions, and visualize or reframe it in a way acceptable to the person involved, and with this reframing such that both the original threat and the threatened situation can be safely abandoned. So we are trying to bring a more scary or threatening situation into a more acceptable, reframing it in a way that it will be more acceptable for the child. So now to types of communication. The first is verbal, second non-verbal, and the third both verbal and non-verbal. So verbal communication is usually by speech, or basically by talking. Next is non-verbal communication. So under that comes body language, smiling, eye contact, facial expressions, showing concern, touching, patting the child, giving the child a hug. The third type of communication is both verbal and non-verbal put together. Now into the second type of non-pharmacological behavior management, that is behavior shaping or modification. So under this comes three. First is desensitization. Next is modeling. And last is contingency management. So behavior shaping basically involves use of selected reinforcers when learned will hopefully change child's behavior from inappropriate to appropriate. So this is based on a stimulus. We give a stimulus and the response that is given. So this is based on a stimulus response theory. Now step-by-step procedure to make, this is basically a step-by-step procedure to make the child involved and get done with the dental therapy. So begin with desensitization. This was proposed by Joseph Ward in 1975. It is accomplished by teaching the child a competing response such as relaxation, and then introducing progressively more threatening stimuli. So effective method for reducing maladaptive behavior. So basically we are trying to relax the child and then we are introducing the more scary or threatening stimuli. So an important desensitizing method here is tell, show, do. Now looking into tell, show, do. So tell, show, do, it was proposed by Adelson in 1959. So it is very easy to use this technique in dental setting. So it is one of the main methods of behavior management, and it's foremost efficient and it doesn't it's non-invasive, and it's very effective in children above 3 years. It is used to orient the child gradually to anxiety provoking stimuli in such a way that he or she will be able to cope with the situation. So basically we introduce things to the child so as to relax them first and then introduce the more anxiety provoking stimuli. Since both verbal, so in this there is both verbal and non-verbal stimuli. So first is interaction, sorry. So first is verbal. So verbal, the tell part comes under verbal interaction, and non-verbal part interaction is when we show and do it. And yeah, interactions, since both verbal and non-verbal interactions are available, dentists can overcome the dental related anxiety. So tell, show, do is most indicated in the first visit or dental visit of a child in children about 3 years, and also in subsequent visits when a different type of dental procedures introduced to the child, also in very apprehensive children. So this is the tell, show, do. So the tell is verbal explanation of procedures in phrases appropriate to the development of the patient. So we explain to the child according to the age of the child and also the vocabulary. We as dentists explain what we are going to do. So this comes under the tell interaction of this procedure. Next is show. So we demonstrate to the child what we are going to do. So in such a way that he or she hears, smells, feels, sees what is going to happen. So demonstration for the patient of the visual, auditory, olfactory and tactile aspects of the procedure, and it is carried out in a very defined, non-threatening way. So as in if we are showing the air odour, demonstrating the air odour to the child, we don't place a burr on it. We can, or if we are placing a burr by chance, we have to show it on something which is something like a dummy, but not on something that will scare the child. Next part of this is do. So do is without deviating from what we have shown to the child, demonstrated to the child, explained and demonstrated to the child, we do the procedure and complete the whole process or the treatment. Now there are variations for this. So tell, show, do, the variations are tell, touch, do, and tell, touch, smell. So this comes for blind children because they cannot be shown. So tell, show, do is not possible for them. So instead of that, we explain to them, then they touch it and then we do it, or they get to smell it before we do it on them. Next is show, touch, do, and show, touch, smell. So this comes for mainly deaf patients. That's because they cannot be told what is going to happen. So we show them, we can make them touch it, and then we do it, or we go to the smell and then do. Next, we are going into modeling, which is the next type of behavior shaping. This was proposed by Bandura in 1969. So it is allowing a patient to observe one or more individuals who demonstrate appropriate behavior. So here we let the child or the child patient look up or imitate, help or look or observe another patient or their own parents. If the parents are patients, we can make them as model, or if they are elder siblings or any good patient. So if the child observes the behavior of another person, he or she tries to imitate. Patients will frequently imitate the model's behavior when placed in similar situations. They can improve behavior of apprehensive child with no previous dental experience. So suppose a child is very scared and enters the dental clinic. If we can show them a good model, then the child will be more relaxed, and also the child will try to imitate that behavior. So in the good point, the advantage of this modeling is that no additional equipment, personal or alteration is in the dental routine is required. So modeling can be done by live models. So as we mentioned, siblings, parents are live models. Also filmed models, like we can show cartoons to them, or animated videos of children or different animals undergoing dental treatment. Then posters and other audiovisual aids can be used as models. It is effective when the observer or is awake and alert. So it's usually more effective for children mainly about 3 years and all. So the child should be awake and alert, and also the model should be according to the child or the person who's observing, or the child who's observing. The model should be considered in a higher position and a higher status and prestige than the child himself. And if the positive behavior of the model is rewarded, then uh, the child who's observing, or the younger sibling, or the child will also want to do behave properly, so that he or she also gets the gift or the reward. So model has relatively positive consequences associated with the behavior, will also make it more effective. Next is the contingency management. This is the next type of behavior shaping. This is a method of modifying the behavior of children by presentation or withdrawal of reinforcers. So basically, we are trying to modify the behavior by either we are giving something, or we are reinforcing something by presenting something to them, or withdrawing something from them. So there are basically two uh, types of reinforce. One is the positive reinforcers, second is the negative reinforcers. So now positive reinforcers is one of which contingent presentation increases the frequency of behavior according to Henry. So this is positive is when something is presented. Negative reinforcer is one which whose contingent withdrawal increase the frequency of behavior. So this is when something is withdrawn. So that is called a negative reinforcer. Now there are three types of reinforcer that we usually use. First is the social reinforcer, next material reinforcer, and third is the activity reinforcer. So first is material reinforcers. This is very effective in children. So we can give them gifts, small toys, stickers, etc. This is by getting these, the children feel very rewarded and they will want to come back to the dentist. However, giving candies and cookies are discouraged because these can cause scabies in children. Next is social reinforcers. The majority of all reinforcer events affect human behavior. So this is related with the social relationship with the child. It should be dispensed throughout each visit, and so basically social reinforcers are something that is given every time the child visits the dental clinic. So once the treatment is finished, or if the child has an appointment and the appointment is over, we should never neglect the child. So what we do is praise. We can different types of social reinforcers are praising the child, showing positive expression, nearness, physical contact, shake hand, like patting their back, etc. These are all different types of social reinforcers that can help shape behavior of the hesitant and inexperienced patient. And if the patient is new to the treatment, it basically helps them to shape their behavior. And if the child is very anxious, it's a method of reassuring them. Next is the activity reinforcer. So this basically doesn't come into much effect in our dental treatment, in the dental operatory actually. So however, this involves the opportunity or the privilege of participating in a preferred activity. Like for example, we can reward or the parents can reward the child by letting them watch TV or going out to play, etc. But that doesn't really come into being when the patient is coming to the dental clinic. So this is more into like home programs like plaque control, habit breaking therapy. So if this if we can encourage the child that if he or she wears their appliance correctly or is brushing their teeth properly, then we'll tell them, okay, if the parents can say that if you do it correctly, there you can be awarded by watching TV for half an hour, etc. After communication and behavior shaping, now we move into the behavior management techniques. So this is not an application of individual technique, but like we when to deal the child, but it is like a comprehensive methodology meant to develop relationship between patient and doctor. It is not a technique just to deal with the child and finish off the treatment. Basically, this helps to maintain a relationship between the dentist and the child. So under this comes few methods. First is audio analgesia. This is otherwise known as white noise, a technique providing sound stimulus of such intensity that patient finds it difficult to attend anything else. So this is said so by Garner and Linder in 1959. So basically we're giving them a stimulus. So the sound stimulus is like music or it can be any sort of basically sounds that it's a stimulus that's given to, sound stimulus which is given to the child. This is high intensity and it masks the sound of aorta, etc. And the child will not be able to concentrate on the sound of the aorta or the air syringe, etc. because the sound is of high intensity. Normally, we play pleasant music. Next technique is the biofeedback. This is use of certain instruments to detect physiological process associated with fear. So there will be different machines or uh, that measure our different vitals, or rather things like BP, etc. are measured. So it is useful in anxiety and stress related disorders. So what we use BP, electroencephalogram, electromyogram, so ECG, etc. BP machines are used. So we can measure the level of anxiety in the patient. Next is humor. So humor is basically, it helps to elevate the mood of the patient. So that's also a behavior technique actually. It helps the child to become more relaxed, and we can introduce uh, stimuli to them in a less fearful way through this technique. So basically humor helps to elevate the mood of the child and helps the child to relax. They function as socially, they're forming and maintaining a relationship with the between the dentist and the child. Second is emotional. So there is anxiety relief in the child because the child who can enjoy humor. So it helps to relieve the anxiety in the child, not only the child but the parent and also the dentist. Next is informative. So we'll be able to transmit essential information in a non-threatening way. Next is motivation. This increases the interest. So if we just blankly just go and do the treatment, instead of that, if we add some humor into this whole process, what happens is the child will be more interested and involved into the treatment. Next is cognitive. It distracts the child from the fearful stimuli. Next method of behavior management is coping. So it's a mechanism by which the child copes with the dental treatment. So the definition is defined as the cognitive and behavioral efforts made by the individual to master, tolerate, or reduce stressful situations. So the different efforts made by the child to cope with the whole situation, that is called coping. So the patient under stress prefer to draw comfort or reassurance from an authoritative figure, thus establishing a trust relationship. So here they are trying to when the child is under stressful situation, the child wants to get consoled by someone who he or she thinks has a good relationship with the child itself. Like example, if the parents console, or if someone they know well consoles them or gives them comfort or reassures them, they prefer that under stress situation. So now into the effects of coping. First is behavioral effect, and the other one is cognitive effect. So behavioral is physical and verbal activities in which the child engages to overcome a stressful situation. Cognitive is the child may remain silent and thinking in the mind to keep calm. So this enables a child to maintain a realistic perspective. So this is reality oriented working. Next is they perceive the situation as less threatening. So they accept the reality and then they understand the situation isn't as bad as they expected. Then they calm and reassure themselves that everything will be fine. So that is the emotional regulating cognition. Under this comes also signal system method followed in clinic. So this is something that we ask any child to do. So we tell the child if he or she experiences pain to put up their hands. So that was suggested by Musselman in 1991. So friendliness, support and reassurance and motivation are basically best coping methods that a dentist can use. Next behavior modification is voice control. So this is a controlled alteration of intensity and pitch of one's voice to dominate interaction between child and dentist. So here the intensity and the pitch of the dentist is changed so that the child starts to concentrate or listen to what the dentist is trying to explain. So voice control is usually done in conjunction with physical restraints and or hand over mouth exercise. The change in tone can be from very gentle to firm type of voice, tone. Next comes relaxation. So this is a technique used to reduce stress based on the elimination of anxiety. It involves a series of basic exercises. So these are exercises that are given to the child long before the treatment. So the child practices, or a child who has anxiety practices this. It may take it takes few months to learn these exercises and helps the child relax so that when they come to the dental office, they can come more relaxed. So it takes several months to learn, and which require the patient to practice at home for at least 15 minutes each day. Next is hypnosis. So hypnosis is an altered state of consciousness characterized by a heightened suggestibility to produce behavioral and physiological changes. So this is when the whole consciousness of the child is altered, so that they'll be able to they'll be able to show off their fears. So it's one of the most effective non-pharmacological therapies, but it is usually not practiced unless there is an hypnosis expert or someone has taken training. Only they can do hypnosis. So when hypnosis is used in dentistry, the word hypnodontics is used. This was suggested by Richardson in 1980. The greatest benefit here is that there will be reduction of anxiety and stress. Next is implosion therapy. So implosion therapy is that suddenly we flood the child with some stimuli, which in such a way that they cannot run away from the stimuli, but they have no choice, but they have to just accept that stimuli. So it's sudden flooding with barrage of stimuli which have affected him adversely, and child has no choice but face the stimuli until the negative response disappears. So mainly consists of home, voice control and physical restraints. Next is aversive conditioning. So this is a safe and effective managing Frankel's definitely negative. Child who cries, kicks, makes shows temper tantrums. All this comes on the Frankel's definitely negative patient. So this is an effective method for such children. Effective behavioral management technique for such children. So before we do aversive conditioning, we should attain the parental permission or the parental consent, or at least verbally. Then the two methods which come under this is home and physical restraints. Now into hand over mouth exercise, otherwise known as home. This was introduced by Evangeline Jordan in 1920. So the main purpose of the hand over mouth exercise is to gain attention of the child for better communication. So here the indications are a healthy child who can understand but who exhibits defiance and hysterical behavior during treatment. So home is never done for a child who cannot understand. So, or children who are below 3 years or children who have handicap, etc. So this is not performed. This is performed on children who can understand, but they are just kicking around or screaming and showing hysterical behavior. Yeah. So this is practiced in 3 to 6-year-olds and child who can understand simple verbal commands and children displaying uncontrollable behavior. The contraindication is children under 3 years and handicapped or frightened child, and also in physically and emotionally handicapped children. Now, factors to be considered before applying hand over mouth exercise is that a technique should not be used as a routine procedure for management. Every time if we do it on the child will not feel comfortable or cannot develop a good relationship with the dentist. Before, and also we should inform the parent how we are going to practice this, and we should explain to the parent how and why we are doing this to the child. Next is also we should get a verbal consent from the parent before we practice this technique. Now there are different variations of home. The hand over mouth exercise, that is hand over mouth, the airway unrestricted. This is usually the one we practice, that is the other name for home itself. Next is hand over mouth and the nose and the airways restricted. Next is towel held over the mouth only. Next is dry towel held over the nose and mouth. The next being wet towel held over the nose and mouth. Into the next technique, that is physical restraint. So this is the last resort for handling uncooperative patient or handicapped patients. So this is not something that we'll try at the first of two. We have to, if nothing, most of the times when none of the behavior techniques work, that is when we mostly go into using physical restraints. This involves the restriction of the movement of the child's head, hands, feet, or the body. So the restraints usually required for hypermotive, stubborn, or defiant child. So this could also be due to a physical condition or any disease in the child. Physical restraints can be active or passive. So active is when the parent or auxiliary staff and the dentist, only they themselves help to restrain the child, and a restraining aid is not used. Passive, it is called passive when we use a restraining device. Now into the different types of restraining device. So for body we use pedi wrap, papoose board, sheets, bean bag with straps, towels and tapes. So here we can see a pedi wrap. This is a pedi wrap, and this is the bean bag with straps. Next, that was for the body. Next, for extremities, we can use Velcro straps, towel and tape, posay straps, etc. Now, for positioning the head, we can use head positioner, forearm body support, and for mouth, we can use mouth blocks, banded tongue blades, and mouth props. You can see mouth props here, and also mouth blocks. Last is the other type of restraints that I use, that is straps attached to the dental unit, sheets, papoose board or pedi wrap. So this brings us to the end of non-pharmacological behavior management techniques. We will continue with pharmacological behavior management techniques in the next class. Thank you.